I'm hoping you can see my screen now. Is that right?
Yeah.
Great, thank you. So yeah, thanks again for joining us for this sort of introduction to this project entitled CIPHER. As Barney correctly said, it's a continuously iterative, perioperative, holistic evaluation of risk. And so I'm Dr. James Badger. I'm Research Fellow in Anaesthesia at the University Hospital Southampton, and the project is being led by Professor Denny Levitt and Professor Mike Grocott, who are professors of perioperative and critical care medicine at the University Hospital Southampton and Professor of Anaesthesia and critical care at the University of Southampton. And I think they're both on the call now to sort of join in the conversation. So we sort of put a sort of lay strapline, which I think continuously iterative, perioperative, holistic evaluation of risk. When you think about it, it sort of very elegantly explains what the project's about, but sort of another way of describing it would be using health information to continuously measure risk before, during, and after surgery. And so what I'm going to do is explain what the project's about and some about how we plan to carry out the project, and then go into some of the issues that are not necessarily black and white, and they're key decisions that we need to make about how we carry out this research. And it would really be useful to us to have people to represent public views and patient views. So what we're looking to do is, we're hoping that today you'll understand the project and what we're trying to achieve. And then in subsequent sessions, we would sort of be hoping for contributors to come forward to sort of give us some ongoing support. So this project is all about risk, and risk is the possibility of something bad happening. And these are some examples of risks, of everyday risks reported by John Paling in his popular science book, Up to Your Armpits and Alligators. And you can see that the odds of a particular risk range from relatively high, so 1 in 85 is the risk of dying in a road traffic accident over 50 years of driving, to very low, which is being hit in your home by a crashing aeroplane, which is 1 in a quarter of a million. But I think the important thing is this is a very simplistic estimation of risk, and I think you'll all appreciate that risk is not the same for everyone. So yeah, for instance, if you lived at the end of a busy runway, then your home might be more likely to be hit by a crashing aeroplane, for instance. And so there are sort of more complex patterns that affect these risks, and there are probably many factors that affect an individual's risk. But the other thing to mention is that your risk will change over time. So if you're looking at your risk at a particular point in time, it won't always be the same. And to give an example would be if there's adverse weather conditions, for instance, your risk at that particular time might be greater than of your home being hit by a crashing aeroplane than in good weather conditions. So risk can also change over time. And risk is really important in making health decisions. In particular, it enables the identification of those who are likely to benefit from surgery, and those who might benefit from surgery but need additional support to help them recover. And I think it also allows the patients to understand the possible outcomes of surgery. They might benefit from specific treatments to help support them through, and also I think it helps people plan for the future. And at the moment, there are formal measurements of risk used in practice, and these input into the shared decision-making process, and this is the sort of accepted way that that decisions are made in healthcare. So the clinician, who's the doctor or a surgeon, for instance, they provide information and recommendations. The patient provides their values and preferences. They make a shared decision together, which will be the best choice or the best option for that specific patient. And the information given by clinicians is usually based on a clinician's individual experience and preference. And they may decide to use a tool to evaluate risk, but these tools are fairly simple. They're based on a limited number of factors, and this is just at a single point in time before an operation. However, it's likely that there are a large number of complex patterns within sort of extremely extensive healthcare information that's available to clinicians, but these are sort of currently too complex to recognize. And further to that, there's not one decision when someone has surgery. So there is a decision about whether they decide whether or not to proceed with surgery, but along that person's surgical journey, there will be multiple clinical decisions made at various different time points, which will affect the outcome of that surgery. But current ways of estimating risk are solely used in the preoperative period. But it's likely that that the risk changes over time based on subsequent events. So this research, so CIPHER, is intended to develop a tool that uses the wide variety of healthcare information about patients in order to continuously pick out complex patterns of risk in and around the time of surgery. And the idea is that this would inform that shared decision making. It could alert doctors that something bad or unexpected is likely to happen, and it can allow timely actions to help address the cause and manage the consequences, and ultimately improve how patients recover from surgery. So in order to develop CIPHER, we need to use health information. Whenever we go to a clinician or a hospital, information is collected about us, about our health and our lifestyle, and this is recorded in our patient record. It might include things like our height and weight, whether we smoke, how much we drink, details of allergies, what aches, pains and infections we've got, what medication we're taking, information about blood tests, images, scans, procedures we've had. So it's sort of a really extensive amount of information contained within that. There's also national data, and this is information that's reported to the NHS centrally. And this contains information such as admission dates, procedures that individuals have had, and information relating to survival. There's a wealth of information also contained within bedside monitors, and this would include information such as blood pressure. And this is important because it sort of gives an indication of how someone is doing at a particular moment in time. There's sort of increasing research around the areas of using monitoring data to, or picking out complex patterns within monitoring data. And so this is a sort of a particular area of interest. There's also potential to use wearable or information from wearable technologies to inform this CIPHER tool. Wearable technologies aren't currently used routinely in clinical practice, and it might include things like activity trackers or a respiratory rate monitor. And they have the potential to give us a vast amount of information about people before their operation, during their operation and after their operation, and how they're recovering. So that's also an area of interest. So the NHS uses the information it collects to provide the best clinical care for us. But that same information can be used to help predict risk. And that's what we're going to try to do. So an important aspect to this project is the legal basis for accessing information. And the legal basis is that we believe that this project is in the public interest. We think it will improve the way that patients recover from surgery, ultimately. However, it's important that we do not use more information than is necessary, and we protect it appropriately. So the patient record contains sensitive information about our health, and so it must be handled very carefully and accessed safely and securely to protect confidentiality. The patient record is contained within the NHS, and that's protected by a firewall, which you can see in this diagram. Before it leaves the NHS systems, it will undergo a process called depersonalization. And that is removal of information that can directly lead to an individual, such as their name, their address, and their telephone number. And then this depersonalized information will be stored securely within a separate database, which is also protected by a firewall. And it will only be used for completing the objectives of the CIPHER study by CIPHER researchers, and the access to this will be via sort of username and password. There is also opportunity for external researchers to use this information for projects that would be beneficial to the public, and they would be able to request access to this information, but this will be subject to appropriate checks. There'll be a legal agreement in place to share this information, and also it will undergo further depersonalization. So that is removal of any unnecessary information that is unnecessary to achieve their objectives. So it's just another way of protecting the patient's information. So this work is being funded by a company called Edwards Life Sciences Corporation. So the initial stages of this work. Edwards Life Sciences Corporation is a US-based company, and they have particular expertise in developing information-driven technologies in the field of bedside monitoring. And they have considerable expertise using bedside monitor information to predict events such as low blood pressure. We're also collaborating with a number of different NHS hospitals in the UK and also a hospital in Australia. And this is important because it's well known that there are important regional differences in health. And so we must really capture information from as wide a variety of people as possible. And this would mean that the tool would be applicable to a wider variety of people. If we only collect information from a select group, it's likely that any tool developed would only usefully apply to that group. And so it's important that we include other hospitals and then in due course extend this work to other hospitals as well that aren't initially collaborating with us. So the one reason that we'd really value patient and public involvement is to help balance the potential health benefits with the public confidence in data security. We all increasingly rely on digital technologies across all areas of our lives, and most of us benefit from access to online services and tailored information when we need it, based on information either about us or people like us. But at the same time, there have been reports of information misuse, such as Facebook and Cambridge Analytica, which highlight the implications for privacy. And so we think that there'll be some people who will be willing to share data about themselves widely. Some people are happy to use social media and store loyalty cards, for instance, but we also think there'll be others who are more cautious. And I think probably individuals are prepared to make different trade-offs depending on what the benefits are likely to be. And it may also depend on the type of data used. such as does it relate to finances, health, travel, or purchases. So in the same way that we benefit from tailored information and from information from other people in our sort of personal lives, when we're treated by the NHS, we also benefit from insights based on previous patients like us. And these benefits for both individual care and to improve health care and services across the NHS really must be balanced with confidence in data security. So in this diagram, I've got a very rough sketch of a weighing scale or a balance, and I've listed some potential trade-offs at each end of the weighing scales that are relevant to the CIPHER project. So firstly, we've got we need the information that we collect to be widely applicable to a wide variety of people. In order for patients to benefit from insights gained from others like them, we have to include others like them. And if we can't capture this information because certain groups of patients are missed from, for instance, from our consent process, then the benefits will be limited. And due to the complexities of surgical pathways, and by that I mean people end up having surgery via a large number of routes through the hospital and specialties, it's not possible to get written consent from everyone. So secondly, I've got new technologies which must be balanced again against commercial access to information. So we hope that we can use the information we collect to create new technologies for patient benefit. But in order to do this, we would need to provide information to external companies, such as Edwards Life Sciences, with the relevant expertise to turn that information into a new technology. So thirdly, I've got detailed information, and that must be balanced against willingness to share. So we would like to collect as detailed information as possible. But as I say, this needs to be balanced against what people would be willing to share. And an example would be if we wish to use wearables such as activity trackers to collect information about patients' health at home. We would like to know, will people be willing to share that information, and would they feel that it's acceptable and unintrusive? So here are a few key questions that we would like to sort of explore in subsequent sessions with an involvement panel to gain some patient and public views and insights. And so the first we've got, would it be acceptable to have an opt-out approach to consent? And that relates to the issue of being able to capture people from a wide variety of pathways, or not being able to capture people from the wide variety of pathways and limiting the potential health benefit by our consent process. So instead of people opting in by signing a consent form, would it be acceptable to have an opt-out approach where if they don't want to take part, they say? So secondly, we've got how would the public feel about sharing information with company-based researchers, and how should this be communicated? How do we articulate the benefits of collaborating with companies and ensure that the public are confident in our information security and that the information won't be misused? So thirdly, we've got what would be a fair deal. So if we're providing information to company-based researchers to provide a technology or to develop a technology which would be of public benefit, clearly they're commercial organizations, so it would result in some sort of product. So what should we be making a deal? Should we expect anything in return? Should we provide information free to all to sort of level the playing field and for maximum potential public benefit? Or should we expect, for instance, free or discounted products in the future? in recognition of our contribution, or should they provide money to help support the research? But clearly that's not a black and white area, and we would like to know what the patients and public feel would be fair and expected. So fourthly, we've got what do patients need to know and how should this be communicated? So if this tool was to be used in shared decision making, what would patients want to know, and what would they need to know to use this tool, CIPHER tool, effectively? And then lastly, we've got which new monitoring technologies would be acceptable. So for instance, how would activity tracking at home be felt to be? Would it be intrusive or unobtrusive? And so would it be acceptable, essentially? So that's the end of my presentation. I hope you've sort of got a grounding in what we are trying to achieve. And yeah, it'd be really good if people have any questions about the project. If there's anything that's unclear or you'd like further explanation on, then that would be great. Is it best if